Okay, our presentation for today is Gestational Diabetes, Long-Term Metabolic Consequences. Our presenter is Dr. Sandy Ramos. She is an Associate Clinical Professor of Maternal and Fetal Medicine at the UCSD School of Medicine. And let me turn this over now to Dr. Ramos.
Good afternoon. Is everybody able to hopefully see my screen?
Yes.
I wanted to thank Cynthia for the nice introduction, and today we're going to be talking about gestational diabetes, the long-term metabolic consequences for both the mother and the fetus. Here's a brief outline of my talk. We're going to be discussing the population rates of obesity and type 2 diabetes. We'll talk about the relationship between obesity and metabolic syndrome. We'll review the new diagnostic criteria for type 2 diabetes as well as for prediabetes. Then we're going to talk about the fetal and neonatal effects of gestational diabetes, some of the long-term maternal effects of GDM, and some interventions that we can employ to prevent the development of type 2 diabetes in these women. So as you all know, the rate of obesity is increasing in the United States. And if we look across the last 20 years, there's been a marked increase in the rate of obesity, such that there are very few states in the United States now that have a obesity rate of less than 20%. Mirroring this rise in the rate of obesity, we are also seeing an increase in the rate of type 2 diabetes, such that over 9% of the population now, or half of the U.S. population, have a high rate of type 2 diabetes. And this is new data from the CDC that you can actually obtain through the CDC website. But not only are we having to deal with an epidemic of obesity, such that 1/3 of the women in the U.S. are obese, but about 60% of them are either overweight and obese, which is quite a burden of illness that we're going to have to be dealing with. And of course, this puts them at risk for many other issues that we're going to touch on. The American Diabetes Association estimates that about 11% of adults have diabetes and about 19% are pre-diabetic. So again, this very much mirrors the population trends for obesity and overweight in the United States, such that 29% of the adult population has some sort of glucose dysregulation that we are going to have to be responsible for caring for. And this is getting a lot of wide attention, and also has gained attention from high-profile celebrities such as our First Lady, not only because adults are obese, but our children are also obese. In this study published in 2005, studying children age 4 years of age, about 18% of those preschoolers were obese. And of course, as you know, we see a higher rate of obesity in different ethnic minorities. For example, in the American Indian population, it's about 30%, in the Latino population, about 22%, and so on. As you can imagine, being an obese child then places you at risk for being an overweight or obese adolescent, and then, of course, the cycle continues. Now, this is a schematic on obesity, which of itself would be an hour-long discussion and presentation about the effects of obesity in pregnancy and the long-term metabolic complications of obesity. However, I just want to focus on this very simple schematic just to come back to the idea that obesity is actually a pro-inflammatory state. Obesity lends itself to interactions with our immune system and brain in such a way that it predisposes to premature death. In this schematic, as you can see, the adipose tissue is made up of blood vessels as well as adipocytes, macrophages, and T cells. It appears that there's an interaction between leukocytes and adipocytes in such a way that inflammatory cytokines are secreted, leading to overall tissue inflammation. This feeds back into the immune system, leading to immune dysfunction and, of course, the predisposition for some cancers, such as colon cancer, but it can also affect other end organs, such as the heart, leading to cardiovascular disease, and, of course, the development of insulin resistance in type 2 diabetes, which is what we worry about with gestational diabetes. This also feeds back into the brain, leading to some mood disorders that you are aware of, such as depression. But cumulatively, this leads to premature death, and obviously is a very huge epidemiologic issue that we're going to have to be dealing with. Now, we think that obesity leads to type 2 diabetes by development of what we call metabolic syndrome. Okay, and again, this is a topic that we can spend an hour discussing, and I'm just going to talk for a few minutes about metabolic syndrome in relationship to the development of type 2 diabetes. But metabolic syndrome is a complex syndrome whose pathogenesis we really don't fully understand. We do know that there is something to do with insulin resistance and abnormal fat distribution, particularly central adiposity. And we know that central adiposity is associated with elevated insulin resistance, as well as C-reactive protein and also inflammation. The characteristic features of metabolic syndrome include obesity, which we've talked about, insulin resistance and or diabetes, dyslipidemia and heart disease, as well as hypertension. And we know that adults that have metabolic syndrome have an increased risk of type 2 diabetes as well as premature cardiovascular disease. And not to be repetitive, but as you can see, the rate of metabolic syndrome is also increasing, not surprisingly, and we are seeing higher rates of metabolic syndrome among ethnic minorities. If you look at Latino women, for example, about 35% of Latino women now are currently being diagnosed with metabolic syndrome. Now that we've established some of the population trends that we're seeing, we're going to talk a little bit about the diagnosis of type 2 diabetes and prediabetes and what's new. In 2010, the American Diabetes Association issued new guidelines to redefine the diagnosis of diabetes, and they incorporated an A1C into the criteria, such that an A1C of 6.5 or above was added to the diagnostic criteria. A1C was added because now we are able to measure the A1C in more of a standardized manner, and as you all know, it doesn't require the patient to be fasting, while the other tests do require the patient to be fasting and can be cumbersome because you have to schedule patients to come back in a fasting state. They kept the same definitions that we employed in the past, including a fasting plasma glucose of greater than or equal to 126, or a 2-hour plasma value of 200 on a 75-gram OGTT. And of course, they kept the classic diagnosis of type 2 diabetes, which is hyperglycemia or a random plasma glucose of greater than 200 and other symptoms of hyperglycemia. But the American Diabetes Association not only added an A1C criteria for the diagnosis of type 2 diabetes, but they also added an A1C criteria for the diagnosis of prediabetes. And they suggested that A1C of 5.7 to 6.4 is abnormal. If you look at studies looking at A1C, people who have an A1C in this range have a 5-year cumulative risk of developing type 2 diabetes of about 12 to 25%. Now, some of the internists out there may worry that an A1C of 5.7 is quite low, but truly studies have been shown to demonstrate this association. The American Diabetes Association also kept the diagnostic criteria for impaired fasting glucose, which is a fasting plasma glucose of 100 to 125, and of course impaired glucose tolerance, which is having a 2-hour value of 140 to 199 on a 75-gram 2-hour OGTT. The American Diabetes Association also took a step forward and said that we could employ the same diagnostic criteria early in pregnancy to diagnose women with overt type 2 diabetes. Again, this move was made because we are seeing such a rise in obesity and metabolic syndrome that many women are walking around with type 2 diabetes and are undiagnosed until they enter medical care during a pregnancy. And so they recommended using the same criteria of fasting and A1C and a random plasma glucose of greater than 200 to diagnose type 2 diabetes in the beginning of the pregnancy. And this actually is a very powerful endorsement for all of us who take care of women with hyperglycemia in pregnancy. Now that we've discussed how to diagnose type 2 diabetes and prediabetes, we will talk about the neonatal effects of gestational diabetes. So in 1952, Dr. Peterson was the first to note the association between maternal hyperglycemia in the development of macrosomia. What he hypothesized was that glucose freely crosses through the placenta and leads to fetal hyperglycemia, which then induces fetal hyperinsulinemia, and then the development of macrosomia. We are now able to measure what we call umbilical cord C-peptide, and a C-peptide is a pro-insulin molecule, and we've noted that infants born to mothers with diabetes may have this elevation in C-peptide, which suggests that there's fetal hyperinsulinemia that is occurring in the womb. Early in the 2000s, Dr. Debelea, did publish this landmark study looking at Pima Indian population that has a high risk or high incidence of type 2 diabetes and obesity. And what she did was she compared the index pregnancy where a mom was not diagnosed with diabetes and compared that to a subsequent pregnancy where she was indeed diagnosed with either type 2 diabetes or gestational diabetes, and then looked at the children and adolescents born to these mothers and compared the BMI of these children and early adults. And what she found was that in the siblings who were exposed to diabetes, there was a higher BMI of about 2.6 kilograms per meter square higher in those siblings. Now again, this is a powerful study because these children were reared in the same environment. So you're sort of controlling for environment, if you will, and just looking at diabetes as an exposure in the womb. And as you can see, it can be associated with a higher BMI. Then a subsequent study was published looking at women and controls, women who had gestational diabetes and controls and their children. And what they sought to evaluate was to look at children aged 6 through 11 and classify them as whether or not they had metabolic syndrome. And the way they classified these children as having metabolic syndrome is they had to have a BMI that was above the 85th percentile, a blood pressure that was greater than the 95th percentile for their age, and an elevated LDL and a low HDL. And as you can see, if you were born LGA and to a mother who had gestational diabetes, you had a rate or a prevalence of metabolic syndrome of about 50%. However, if you were born normally sized, you had a lower rate of metabolic syndrome. So not only does exposure to gestational diabetes in the womb make a difference, but also being born large appears to make a difference.